Hi, this is Dr. Torino. I'm here with UltrasoundBytes from VMS, and today we're going to talk about scanning the gallbladder. So our objectives are going to be similar for every presentation we give you regarding scanning instructions, and we're going to have some clinical pearls and some SPI pearls for you to consider. When you are scanning the gallbladder, the things you need to be thinking about clinically: looking inside the gallbladder. It should be an anechoic black pouch, and internal contents could be gallstones or sludge, biliary sludge. You want to look at the wall. The wall should be less than 3 millimeters in thickness. It should be very well defined. There should be no pericholecystic fluid. And then once you have enough practice, you can locate the common bile duct and measure its diameter to make sure it's not enlarged. While you're scanning a gallbladder, typically we think about this as a curvy linear probe, but you can scan with a phased array as well. Remember, you really don't want to make any scanning adjustments in depth, gain, or focal zone until you've begun scanning and really paid attention to the lie of the gallbladder in your patient. Remember your probe marker convention: marker to the head for sagittal, marker to the patient's right for transverse. But in the gallbladder, your markers are set to the gallbladder itself, and there's going to be a lot of sweeping and pivoting because the gallbladder is not going to necessarily lie in a straight, for instance, sagittal line. Many different patient positions. You've heard us say many times in ultrasound that things are not real if you don't see them in two scan planes. Well, in the gallbladder, there's an additional caveat, and that is that you must see it in a different patient position. So for the gallbladder, not only would you have to see, for instance, a gallstone in longitudinal and in transverse, you would also have to move your patient. A good patient position for the gallbladder is always LPO, typically rolls that gallbladder out from the ribs just enough to be quite useful. So I'm going to scan subcostal for gallbladder, and I'm going to have my patient take in a big breath and hold it in, and then I'm going to angle slightly to the right. You might have to angle slightly superior or inferior. Now, if that is a poor scanning window, then you can go to scanning intercostally, and that becomes a useful tool for you. And if held inspiration isn't useful, the other patient help you can try is to ask them to pooch out their tummy, make a big fat tummy, and sometimes that pushes that duodenum and anterior stomach off to the side a bit. So as you begin scanning, you are going to make adjustments to your depth, your focal zone, your gain, and your probe so that you can approach this scan in along to the gallbladder and cross section to the gallbladder. And I'd like to go to scanning now so that we can look at our patient and see how this gallbladder lies. Should be pretty well. So I'm just going to start with my settings however they originate, and here I see the gallbladder automatically and actually fairly longitudinal in the body, but it's pretty superficial, so I'm going to decrease my scanning depth a little bit. And now I'm going to ask my patient to big breath in, please, and I'm going to move and at the same time angle medial and then lateral so that I'm sure I've looked all the way through the gallbladder, being able to look at everything from neck body, and fundus. Breathe, please. Now that I've looked at gallbladder transversely, I'm going to rotate my probe 90 degrees, and big breath in, please. And I'm going to go superior. Remember that the right portal vein is a great landmark to help you find those difficult gallbladders, because when you slide inferior, the first structure you get to is the neck of the gallbladder. Then if I keep coming inferiorly, I go through body, fundus, all the way out. Breathe. And then I'm gonna come back and I'm gonna just center this image for the body of the gallbladder. The only reason I've chosen body here is it's the plumpest, most full portion of this gallbladder. And I'm gonna measure the wall of this gallbladder. And I'm going to set basically from the very outer edge of the wall to the very inner edge of the wall. And you can see that this gallbladder wall measures 2 millimeters. And so normal is anything less than 3 millimeters. So that's very normal. Now I'm going to rotate my probe back to longitudinal, and I'm going to walk you through locating a common bile duct. So what I'm going to do is I slid medial until I see the IVC. And I know this is IVC because deep to it, I see a right renal artery. So now I'm going to ask, big breath in please, and hold it. And I automatically see some tissue from the pancreas and liver, anterior, and I see a very plump vessel, which sitting directly anterior to the IVC is the main portal vein. We see breakfast and the duodenum. And here I see elongated and anterior to the portal vein, a tube, breathe, which is common bile duct. Now I'm going to measure this first, and then I'm going to put color on it to prove it to you, because prove it is always going to be very good. You want to measure your common bile duct where it is fattest, and you want to set your calipers inner to inner. The other thing you have to be aware of is when you set your calipers, they are perpendicular to the wall of the duct, not to AP on your patient. So big breath in please, hold it. So I have pivoted my probe slightly counterclockwise, and now if I put color on, you can see color in everything here except, whoops, let me come back onto it. There's red dot in the hepatic artery, and here again, no flow in the common bile duct. So I can stretch that duct out and it stays devoid of flow. Breathe. Sorry, that was a long one. Okay. All right. So now I'm just going to turn color off. Some people will tell you that when you look for the common bile duct, you should go breath in, hold it, to the neck of the gallbladder, and pivot, rock inferomedial, and rotate a little counterclockwise. That works as well. Here's the duct without color in it. But I think if you go to IVC first, it's much more reproducible. All right, now I'm going to go back to some more notes for a moment. And I don't know whether you might have noticed or not, but I did have to adjust the focal zone as differently when I looked at the ducts compared to when I looked at the gallbladder. So there are going to be dynamic changes that occur. So some scanning pearls and pitfalls in the gallbladder. Gallbladders can be very difficult to find. They are not always going to lie where you think they should be. So my biggest takeaway for you is if you're trying to find a gallbladder, find the right portal vein. It's big, it's in the liver, you can't miss it. And then slide inferiorly. And the first thing you come to will be the neck of the gallbladder. And then you can follow it and figure out where the gallbladder is lying. What are some artifacts? Common artifacts that you'll see around the gallbladder: edge shadowing. We see it quite often. It's a refractive shadow, and you see it at the edges of rounded structures. Another artifact that you'll see in the gallbladder that you have to be a little bit careful on is anterior cystic noise. And anterior cystic noise is actually a reverberation that occurs at the anterior wall of the gallbladder. There's 2 layers to any wall, and the sound is just bouncing back and forth in those walls, and you get this noise anteriorly inside the lumen. The lumen should be black. And you have to decide whether it's a gallbladder and is this thrombus, or whether it's a gallbladder and is this sludge. Is it real or is it artifact? And what you have to remember is if these echoes were real, then they would layer dependently and would not be part of this anterior wall complex. So that's what you have to think about, is are they dependent in the body or not? Labeling, of course, you need some identifier for what you're looking at and what course it's part of. And then on your scan itself, over in the corners that don't have image in them, your name, your ID, and some anatomic identifier. If you're doing this as a lab, you're also identifying the IVC, the aorta, and you're measuring the gallbladder wall and, in this lab, mid-aorta. So when you measure wall, you're measuring wall from edge to edge, and the normal wall should be less than 3 millimeters. Remember, what are some things that can make a wall thick? Falsely thick especially. Probably the most common would be your patient isn't really fasting. They're not fasting, they've eaten, and you need to scan them in a couple of hours. Other things, they could have cholecystitis. Other things, they could have gallbladder carcinomas or polyps. So the whole range from totally benign to much more bothersome, and you're going to have to figure out which is which. What are things that make a gallbladder big? You know, we think about a gallbladder as this big pouch, but how big is too big? Well, too big is more than 10 centimeters, and there are 2 primary suspects for big gallbladders. The first is called a Courvoisier gallbladder, and these occur in patients that have an extrahepatic mass, usually in the duodenum or the pancreatic head. And what you're going to find sonographically is a big gallbladder and a big ductal system, especially the common bile duct. The other example of a big gallbladder could be a hydrophilic gallbladder. So these are big gallbladders that are caused by a stone getting stuck in the neck. The difference sonographically is in a hydrophilic gallbladder, the ducts typically are normal. So pay attention to the clinical presentations. Common variants, people have lots and lots of different folds in the gallbladder, and they're named based on where they are. So a Hartman's pouch is a fold in the neck, and a Phrygian cap is a fold in the fundus. And so you'll see these quite often. And then your SPI snapshot. Because we were talking about anterior cystic noise, I decided to talk about Huygens Principle. And Huygens Principle says that many wavelets of sound leave the transducer and they interact with each other constructively or destructively. And they create the sound that travels into our body. Now, sound travels and looks like an hourglass. And when you get to the skinny part of the beam, you're at the focal zone. And the focal zone is at the end of the near zone. So you go through the near zone, you get to the focal zone, and then you go to the far zone where the beam spreads out. And in the focal zone, you have the highest beam intensity. And that's because the beam is smallest here. How are you going to see this when you scan? Often you're going to have a brighter band at this mid-range where your focal zone is. And you'll notice this especially if you have set your focal zone incorrectly. So remember, there's a lot going on inside the body with the sound that you might not be aware of. Some of it you don't even control on your machine. For instance, if you need more depth, your machine is automatically going to use more elements to create a bigger aperture to send more sound into the body. Lots of these things happen through the machine and you have no part in them. They just happen automatically. And now we're trying to make you aware of them one fact at a time. I will be stopping here because the next part of that presentation are scanning cards. There are some scanning instruction cards that are going to be available on Blackboard for you, which list your shortened protocol with your labeling requirements and the image requirements, including measurements. So this is it for Dr. Torino and today's Ultrasound Bites at EVMS. Gallbladder scanning is done for today, and you can let your patient eat. Thank you.